Hello everyone, this is Dr. Mohit, your faculty for Dermatology, and today we will be discussing just the basics of it, and we will see how a clinician should be thinking with this subject. Initially, we will just go on to the very basics, right? But first, we will just have to see, when the patients come to us, what things should be there in a clinician's mind so as to get a perfect diagnosis. So at the end, this is all about the diagnosis, right? And my father always says that your eyes won't see what your mind doesn't know. The next slide is just going to be about that, and we'll have to be very receptive about what the patient says and what questions we need to ask so as we can get to a perfect diagnosis. Alright, so let us begin the discussion. So as you know, right, the skin is the largest organ in the body, right? That is a very basic thing we all know, yes. And first of all, when we see the lesions in the skin, yes, so first of all we have to make a proper evaluation, right? So we have to see how are the lesions, yes, are they grouped, is there any pus involved, or how is the texture, yes. So we have to have a proper evaluation of it. And when in all medicine, right, the terminology has to be very correct. For example, in the next chapter we will see about this word terminology, right? So if it is a papule, pustule, plaque, so when do we use what terminologies, that will be discussed in the next chapter. Recognizing the pattern, yes, and why is probably the patient could have had a hypersensitivity reaction, yes, maybe the patient has allergic contact dermatitis, right? So only when certain agents, it could be chemical agent, it could be a metal, or it could be anything, it gets in contact, it then the patient starts having some wheals on the contacted surface, right? So we should have a proper orientation about the history as well. So history taking is also important, yes. And when we see the patient, so it is very important in derma that we assess the whole body, right? And dermatology doesn't mean just the skin, it also includes the appendages. So it will be the hair and the nails, right? So in lot of presentation, yes, in the trichology part, yes, so we have to have a very clear demarcation, right? So which type of alopecia is it, yes. And probably just give me an example of seborrheic dermatitis, even though it can happen anywhere on the skin, yes. So we have to have a proper thorough check, yes, of the appendages as well, okay. And yes, and the last point over here is we have to have a proper scrutinization of the all morphological characters, yes. So this is something we all do, right? We get into all the nitty-gritty details about everything in medicine, right? So okay, so just to talk more about the history taking part, yes. So when the patient walks in, yes, so first of all we just ask to tell me from when is it happening. So we will ask the duration, yes, and this part, the chief complaint, this is the reason patient is going to come find us, right? And the periodicity, when does it happen, yes. And the next one is evolution. So when the lesion happened and till now, did the patient find any changes in it, yes. So that is what the evolution is. So if the patient says, well, it gets worse when I go outside, so this could be a very important finding, yes. Maybe the patient will say, yes doctor, I had this lesion on my skin, but it is the same since past 15 years. So do you think that this history is a positive history for melanoma or a negative history for melanoma? It is a negative history, so because it should spread, yes, even though it takes a lot of time to develop it, but still the duration is very important. That is it rapidly spreading or it is just confined to that spot, okay. All right, the next one is the location, yeah, where is it happening, and the symptoms pertaining to it as well, yes. And the last point over here is what worsens it, Yes, what factors make it worse, what factors make it better. Yes, so just give an example of an occupational hazard, right? For example, if a person is working in any textile industry, yes, and he is having allergies, right? Just the term allergy we'll use of any agent which he's been repeatedly having exposure to. He comes and tells you that the whole thing is just there during the week, and weekends I'm happy. Weekends I don't have any allergy, I'm home and I'm happy. So the patient thinks that when he is home he is not having any allergy, but when he goes to work he is having allergy, and his wife thinks that the husband doesn't want to work. So probably it's not the case, he is just having an occupational hazard, right? That he is allergic to some substance in the at his workplace. Yes, so this point, that what are the exacerbating factors, right? So not getting exposed to that and getting exposed to that makes a clear demarcation here. Okay, the last thing over here is the past medical history, right? So did the patient suffer something like this in the past? Yes, does they have any family history, right, with that lesion or anything regarding that? Yes, is it a chronic illness, or did the patient had any surgical procedures? Yes, any drugs the person is taking, like maybe he has a organ transplant. Yes, that could be one thing. Yes, and any allergies? This is one thing we always ask, right, in the hospital. Any allergies related to it? Yeah, and social history of being exposed to any outside environment. Do you do anything else than the regular thing? Yes, that is the main thing. Okay, so then probably the patient will open up. Okay, fine. Whenever I go outside for trekking and I come back and I see this whole thing is happening. So probably whenever the patient gets a little bit bruised from the plants or any offending agent, the wheals starts develop in the exposed area. Okay, that is one thing. Okay, all right. So just with this, yes, we can now continue to the next topic. Yes, how do we examine the patient, right? What do we see, how do we see, and all aspects related to it. All right, so first of all, whenever the patient comes to us, right, what we would do it, we would just see the general aspects of the patient. So is the patient anemic? How is the patient looking? And how is especially the skin texture, right, the skin turgor. So basically, like a lot of things we can just see, we can just tell just by seeing the patient, right? Yeah, if the patient is having any sort of tumors, yeah, it could have any sort of any abnormal pigmentation, yeah, skin color, yes, and any pigmentation. Does the patient have any pallor or any temperature changes? Okay, all right. So the next thing is surface changes. Yes, surface changes. This is very interesting point. Yes, why? Because two conditions over here, that for example the patient could have excessive dryness or it could have excessive of sweating. Yes, it could be either dry or it could be either very oily. So if the patient could have excessive of sweating, or there could be decrease in sweating, right? So it could be hyperhidrosis or hypohidrosis. Yes, so I know one of my friend, he has this condition, hyperhidrosis, and his palms and soles, they just so wet all the time. Yes, so as we go on with the subject, this topic will come and we'll see what are the details, what can we do about these patients. Yes, okay. The next point is degree of photoaging. Yes, so I'll just zoom in this part, and probably we must have seen this, right, on our grandparents' hands. Probably at some point of time, probably we would also have it. Yes, but these things are known as lenti genes, right? Okay, because of a lot of exposure on the skin, there is hyperpigmentation patches. Okay, all right. The next thing, when we see a lesion, is we would just try to think, okay, fine, how can we describe the lesion? Okay, all right. So now what I'm going to do is I'm just going to break it here, and I will get you to the next page, and we will not describe the image, but I just want you to think and just ask yourself, right? I want you to think that how would you describe the images? Yeah, that is very important. And all these images we would be talking about in a very great details. Yes, but just for the introduction part of dermatology, I want to take things this way. What is this? So, do you see any blisters? Do you see any pustules? Do you see any pus? No. Do you see any inflammation? Yes. Do you see any skin getting sloughed off? No. Right? In the second image, do you see is it very generalized or is it in a very linear fashion? How is it? Does it have a set pattern or not? It has a set pattern, right? Coming to this one, does it have set pattern? Yes, it has a very clear set pattern. Yes. Coming to the next one, yes, this we will, if you know the answer, you know, okay, but we will talk about this topic in a very great detail. Okay, the next one, as you can see, how would you describe this lesion? Yes. Is it flat? No. Is it elevated? Yes. How is it elevated? From the center or from the periphery? From the periphery, right? Do you think we can call it rolled edges? We can call rolled edges, right? And do you see these? What do you call these? Yes, that is the question, right? That is this is telangiectasia. Yes, this one. Usually, a lot of guys, we after we're done with the shaving, and we have some folliculitis, and probably this is an after shave or just one hair getting affected. How would you describe this? Is it grouped vesicle or not? It is not. It's just a single pustule. Okay. All right. So how about this one? How would we describe this? Yeah, this is it? Do you think this? Even though this image is not that clear, but at least we can say that this looks like a crusty lesion, right? Or does it look like absolutely normal? Surely it doesn't, right? We will call it a crusty lesion. Yes, crust and scaly in the center. Yeah, and in the periphery it is very clear, right? The edges are very clear. Okay, just like this, I just want to ask you how you describe this. Yes, and these images as well. So the point, let us discuss this as well, right? So how will you describe this? Do you think this is elevated or it is depressed, or do you think how are the lesions? Are the lesions like this, or are the lesions just like this? Yeah, these lesions are like this, right? There is central umbilication. Yeah, okay. How about this one? Do you think this is elevated or it is depressed? How is it? This is elevated, right? Do you think does this have a very clear margin or not? Relatively clear margin. Okay. This one, this very angry looking, yes, what is this? This is a carbuncle, right? Okay. But yes, okay. This one, how would you okay, fine, we see this, we say okay, fine, there has to be some extravasations of blood in the dermis. Okay, fine. What would you call this? What would you call this? Yes, so we will be learning all about this thing in very great details as we go ahead. Even in the next chapter we will see a lot of things just to describe the morphology, right, of the skin. All right, fine. So that was all about these things. I just wanted to expose you, yes, just pertaining to this topic. And now coming back to the distribution of the lesion. So where is the lesion, right? Is it localized or is it grouped? Is it symmetrical or is it just at one place? Is it happening on sun exposed areas, or is it at the flexure area or extensor area or the flexure areas, right? So all these things we have to know why to describe the lesions properly. Okay, that is the reason I added a very extensive list in this chapter. Okay, all right. So the next one, the primary lesion. This guy is the first guy who comes. Okay, the primary lesion. Whenever we ask a patient, so we say, which was the first one? Yeah, you got it on the trunk, or you got in the mucosa, or you got on the chest, wherever you got it. Where was the first lesion, right? So this first lesion thing, I will come back, yes, whenever we read a topic. Yeah, okay, fine, with this first lesion thing. Okay, all right, and we define their shape, type, shape, and the secondary changes. Yes, and the last thing is that we have to palpate, right? We have to palpate the lesions and see how is the texture, right, of the lesion. Is it, we feel, is it very superficial or is it deep? Yes, and is it very firm or rubbery, or is it a very mobile lesion? Okay, all right. So that is all about the physical examination in dermatological diagnosis, right? So I hope with this there was a little bit of understanding about what we are getting into, rather than just going into the epidermis, dermis and hypodermis and talking about all the greater details. I want you to think that how would you speak, how would you describe a proper lesion when the patient is in front of you, how words will you use. Definitely in the next chapter we'll talk more about it, but I want you to think what is dermatology basically, right, and how should we think when, so that we should not miss a diagnosis when a patient is there in front of us. All right, now let's continue and talk about some physical examinations that we have to do as well, right, whenever we have a patient. So one of the things that we would do is check the lymph nodes, yes, of the patient. You know, probably is there any because of the metastasis, is there any abnormal swelling? Yeah, we would check that, and we would check the vital signs of the patient, and is there any hepatosplenomegaly. So this thing definitely comes in the general examination, right, of the whole body. Now we will continue our discussions about introduction of dermatology, and this part we will be taking just the basic pathological units. Yes, the reason I want to teach this topic is because just to get a clear idea in the head, right, if there is a pathology happening in one part, so where exactly it's happening. Definitely in the next 15-20 minutes we will be learning about all the layers of the epidermis, dermis, hypodermis, everything will be discussed. But this thing, I just want you to have this image in your mind. All right, so let us begin. Basic pathologic units. All right, so first of all, if you see right in the diagram, let me just get into the diagram. Yes, so this is the superficial reactive unit. Okay, so this is just the upper part, right, the superficial part. Yes, and this part is a deep reactive unit, DRU. Okay, and the last part is just the subcutaneous part. Yes, and now let us see the superficial reactive unit, deep reactive unit, what do they each have? Okay, just to get an idea about it. All right, please don't get intimidated about all these facts just being discussed in the introduction. Okay, all this is just to give you a very good holistic approach how to enter the subject. All right, so let us just start. So the superficial reactive unit, right, so this has the epidermis, and there is a junction, there is papillary bodies. Okay, so these things are important in here. The next part is the deep reactive unit. Yes, if you just observe the diagram very clearly, that this part does not have any of the veins and the arteries like the capillaries. There are no plexuses, no nothing, right? So where is it? So it's in the deep reactive unit. All right, so we can also see the reticular dermis, right? If right here we have the reticular dermis. Okay, and there is deep venous plexus. All right, deep venous plexus is found in the deep reactive unit. Okay, so we go to the next part. Yes, this is the subcutaneous part. Yes, in this we have the septa and lobule. All right, mind you everyone, whatever things have been discussed here, each things are going to form our basis for future lectures. Each thing will have its pathology and the clinical correlations, and we will discuss everything in a very great detail. So if you listen to these concepts in the first chapter very clearly, I can be very assertive, right, that this will help you to understand the clinical correlations ahead. Okay, all right, so let us just revise the thing we just learned. Okay, superficial reactive layer. Yes, so this had epidermal junction zones and the papillary bodies. yes, and with this vascular system. The second reactive layer, it was a deep reactive layer. Okay, it had the reticular dermis and the vascular plexus. We just saw in the diagram as well. All right. The third layer, yes, the third layer, the one in the bottom, right? This was subcutaneous tissue with septa and lobular compartments. Okay. So let us just go back to the diagram once again and see these things. Okay. Now as you can see, the superficial, the deep and the septa, we have the epidermis, the junctional zone, yes, and the papillary bodies, and in the deep reactive unit we have the reticular dermis and the deep venous plexus right here, and in the subcutaneous part we have the septa and lobules. Alright, fine. Okay, so now let us continue to the structure and function of the skin. Alright, so till here it was all about getting to know the subject and how we should approach the things, right? So now starts all the greater details, and what things we should memorize, what things should be focused on, all the details will be discussed here. Alright, so let us start. So this is very basic, right? So we also learned this back in our school days, layer of the dermis. So epidermis, dermis, hypodermis, right? So the same thing here, yes. The first is epidermis, yes, dermis and hypodermis. Okay, one question, yeah, that will be the next topic of discussion. What is the function of these things? Yes, so that is what we should know. First of all, it is providing a very good immunity to us, right? So because the external bacteria and stuff cannot enter into the systemic circulation, because skin is the largest organ, is also giving us a very good protection. Yeah, so that is one of the function, right? And it also acts as a very good, it is a permeability barrier. Yes, it provides a very good permeability to the things, right? So it's very selective for the things it wants to remove and accept, right? So that is for the epidermis. So let us just write it down, that epidermis. So the major function is it would provide permeability. Alright, it will provide us a good permeability, and the next one is it would give us a good innate immunity. Okay, and it does give us adhesion and ultraviolet protection. Yes, so this is the part of the skin, right, which gets exposed all the time. Yes. Okay, dermis, the next one. Yes, so dermis has three major components. Yes, so first component is the cellular one, the cellular component. This is the cellular component. The next is the fibrous matrix. And the third one is diffuse and filamentous matrix. Mind you, dermis was the layer which had the venous plexus was present, yes, and we had a good vascular supply in dermis. Okay, so it has a very good vascular and lymphatic networks. Okay, that is the next point. And hypodermis, what does hypodermis do is this basically gives us a very good insulation and mechanical integrity. Yes, it gives us insulation and mechanical integrity. Okay, alright, so that was all for the epidermis part. Yes, epidermis, dermis, hypodermis. Okay, so that was all for the layers of skin, right? Just in a very holistic manner. Epidermis, dermis, hypodermis, what are the functions? Okay, and the next thing I want to ask you is, now we will just learn about all the layers of epidermis. Okay, but first, before that, I want to ask you, do you guys happen to like coffee? Yes, so this is one of the things I love. Yes, having coffee first thing in the day is the best thing ever. I love coffee, very big coffee enthusiast. And I also have added some photos from different parts of the places I have been. So the one in the left is I was somewhere in a villa, yes, and the next one is a photo. This is a very good cafe I like. This is in Beijing, yes, and the name is Polonio. This is one of my favorite cafes there. And the next one is 𝗲𝗵𝗵𝗵𝗺. This is a very popular coffee brand in China. Yes, I really love it. Definitely missing it. It would be best if I would had a cup right here. I hope you guys like coffee and you're very big coffee enthusiast like me. Yes. The reason I'm telling you is because I will be using the context in our mnemonic. Okay. So let us come right into the layer of epidermis. Okay. So over here, from top to bottom, I'll just go through, okay, and then we'll learn how to memorize this. Yes, okay. At the very top we have stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and we have stratum basale. Yes, so how would we remember this? So this diagram, as you can see, now definitely I'm teaching you in the next slide. You are the one who will answer me. Okay, next part is going to be the labeling part. Okay, and let us just learn them once again. Yes, so basale, spinosum, granulosum, lucidum, and corneum. Okay, this is the reason why I asked you, do you guys like coffee, or this was the reason. Okay, so that is the mnemonic to remember the layers from the very bottom to the top. Yes, so the mnemonic goes like, big strong guys love coffee, isn't it? We all love coffee. Yes, so big strong guys love coffee. So I'll just add all those things here as well. Okay, so it will make a good memory for us. So big strong guys love coffee. Cafe, right, as we say in Chinese. So big strong guys love coffee. Okay, all right, so I hope this will help you guys. Yes, big strong guys love coffee from bottom to very top. Okay, and stratum basale, stratum spinosum, stratum germinativum. Okay, this germinativum has two names. Yes, stratum germinativum or stratum granulosum, two names. Okay, all right, okay, cool. Let me just write it down very clearly. Okay, cool. All right, so now let us come to the next part. Yes, and over here I will be asking you to label them. We are going to label the whole diagram. Okay, all the cells and everything, and mind you, whatever things we write, we are going to discuss in all the greater details. Okay, so what was the first one? Right here, this one was stratum corneum, right? How about the next one? Okay, stratum lucidum. Okay, how about the next one? Yes, this was stratum granulosum, right, guys? Okay, how about the next one? This one was stratum spinosum. Okay, this was stratum basale. Okay, so now we have labeled all the layers of the skin, right? So big strong guys love coffee. That part is done. But on the other side, you can see, like, there are some cells. Yes, let us go on and label those, and let me introduce you to all the different type of cells we will be learning in the whole demo as well. Okay, all right, at least a part of it. So these cells you see right here, yes, these are keratinocytes. Okay, and how about this one? This one is a Langerhans cell. How about this one? The next one over here is a Merkel cell. Merkel cell, this cell is used, this cell, what is the function of this cell? Okay, we will discuss it at the very end when we discuss the types of cells. Okay, alright, so if you know, you can just think and ponder on it. Okay, how about the next one? This is just a nerve, right? Sensory nerve. Okay, how about this one? What is this? This is providing pigmentation. This is a melanocyte. Okay, and how about the last one? Yes, so this was epidermis, dermis. So this all thing we labeled till now, it was just the part of dermis. It was just a part of epidermis, right? So now the next layer is dermis. Okay, so this is dermis. And also we can say, because it has, you see, the veins and the arteries, yes, capillaries over here. Okay, all right, capillaries and venules. Okay, so that was all for labeling part. Okay, all right, so let us continue from the epidermis. Okay, so now we know, very well aware of all the layers, right? We just read about all those things. We had a very good mnemonic to remember those things, but we don't know the information, right? What these things actually are, what they actually do. We know, like, they provide some permeability and innate immunity, and all these things are quite basic. So let us just get into the details. Let's start. This will be the representation of the whole dermis, epidermis, right, and the subcutaneous fatty tissue. Okay, first of all, the origin, right? This is an ectodermal origin. Let us write down, derived from ectoderm. Okay, all right, this is the thickest layer, thickest in palms and soles, right? Definitely, as we can see, if we just check on our own body, right? So the layer, yes, this is the epidermis, right? It's quite thick, if you can just feel it. But do you think thickness is same as on our eyelids? Definitely not, right? Yes, so on eyelids is the thinnest, and on the palms and the feet it is the thickest. Okay, all right, so the next point we discussed already, that it gives us permeability and adds as a barrier to the skin. Okay, and also provides protection. Okay, so the next one, retiridges and papillary dermis. What are these things? This is a very interesting point. Okay, all right, so I'm just gonna zoom deep into the diagram right over here, and you can see the epidermis and dermis, yes, and the subcutaneous layer. Okay, the epidermis which is there, you can see certain projections. Let me just go and highlight them. Okay, we can see these projections. Yes, we can clearly elicit these. Yes, so but if you watch closely, that the epidermis is trying to enter into the dermis, right? And the dermis itself is giving a good answer. It is trying to enter into the epidermis. They have a very good junction, right? So this right here, the epidermis which is trying to enter into the dermis, these are called retiridges. Okay, did I make myself very clear? What are retiridges? Yes, retiridges are invaginations. Invagination of epidermis into dermis. All right, and how about the next one? The next one is the papillary dermis. Okay, so this guy is the one on the bottom. All right, so the dermis which is trying to enter into the epidermis, this is the papillary one. Okay, alright, so let me just write it down. The invagination of dermis into epidermis. Okay, alright. So the next point is about, I hope this is very clear, rete ridges and papillary dermis. Okay, so the next one is reticular dermis, yes, which is made up of fibrils. Fibrils we will talk about very extensively as we go ahead. Okay, and the next thing is cell differentiation. Okay, alright, so let us come to this point right here. We come to the diagram again. Yes, so if you see right in this diagram, yes, for that fact let us go to the diagram we just labeled. Okay, if you can see, if I ask you a few questions, at the bottom in the stratum basale, do you think there is nuclei? Yes, you can see nuclei. We go a layer ahead and ahead and ahead and ahead, and we go on the topest layer, which is the stratum corneum. Do you guys think, where is the nucleus? The nucleus is gone, right? There is no nucleus here, right? No nucleus. We can see nucleus here, we can see nucleus here till lucidum. After the lucidum, we don't have any nucleus, alright, there is loss of nucleus. Okay, so that is how the way when the cells mature, the cells are produced and the stratum basale, it goes up, it travels up and it just sets off as a nucleus. Okay, alright, so that is cell differentiation. Okay, and we will talk about cell differentiation a lot. So the same point from the bottom to top, the loss of nuclei, yes, and there is no mitosis, yes, the cells are dehydrated, yes, and the next point is, if there is a premature baby, yes, and what do you think in all the layers, right, from the big strong guys love coffee, yes, which layer would not be forming in the preterm babies? It is for obvious, it is the stratum corneum, right? Okay, alright, so that is a thing that the preterm babies, the outermost layer is absent, that is the stratum corneum. It's quite a basic thing, but this was the question which was asked in the exam. Okay, alright. The next is the cell kinetics. This is something we just discussed in the diagram. Okay, that the epidermal turnover rate, yes, this is a figure that it is 56 to 75 days to reach the cell from the very bottom to the top. Okay, it takes 56 to 75 days. Okay, it is a range which has to be answered. Okay, but in psoriasis, okay, so let me introduce a new word here. In psoriasis, what happens is the rate of, there is hyperproliferation of cells, and the epidermal turnover rate, it increases so drastically. It's just 4 days. Yes, just imagine this, the skin reaching from the very bottom to the top. Do you think there will be nuclei or not in this stratum corneum? Answer me this question. Do you think there will be nuclei? Yes or no? Yes. Why? The cells don't have time to shed off the nucleus, right? So if in a patient I take a histological sample, right, where on the affected area, will the stratum corneum have the nuclei or not? Yes. Okay, alright, so that was my point and about psoriasis, and we will discuss about this in a very greater detail. And psoriasis is a very important topic. Okay, this is a star topic of dermatology. Okay, psoriasis, and we will know everything about it. Okay, so next up is the cells in the epidermis. Okay, these 4 guys we'll know everything about it as we go ahead in the end of the lecture. Okay, so it is the keratinocytes. These, so all the cells we marked in our diagram as well. Keratinocytes, melanocytes, Langerhans cells, and the Merkel cells. Let me just give you their functions, right, a little bit over here. So the keratinocytes, these are the main cells in the whole epidermis, right? So the major keratinocyte, these cells are everywhere in the whole of the epidermis. We would find keratinocytes. The next one is the melanocyte. This one is responsible to give us pigmentation. Yes. Okay, alright. This cell is directly not responsible. There are other components of this cell that we will discuss. Okay, this cell is important for the skin color. Alright, the next one is the Langerhans cell. This is an APC, yes, antigen presenting cell. Okay, we will discuss about this as well. The Langerhans cell. Merkel cell, this one is a touch receptor cell. Okay, Merkel cell is a touch receptor cell for fine touch. Okay, we will discuss about this, and we will try to connect the dermatology findings with the physiology things as well. Okay, I'll discuss a table with you guys when I am done with the types of cell, and over there we can definitely spare some time to discuss all the different type of touch receptors, which is a very star topic of all the exams, right? So we can just use the opportunity to have a good revision as well. Alright, so let us move on. Stratum corneum. So what is stratum corneum, right? So this means this is a layer which is keratinized. So stratum corneum, mind you guys, it is the topmost layer. Okay, coffee, right? Corneum, coffee, and corneum means keratin. Okay, so keratin, so how did this guy come suddenly, right? In the stratum basale, do you think there is keratin? Do answer my question. Okay, so the next one is the shape. What do you think the shape is going to be? Tell me. Is it elongated, or how is the shape? Is flat, right? It's a flat shape. Okay, shape is flat. Nuclei, yes or no? No. We discussed about this, right? There is no nuclei, no mitosis. This is the last part of the cell, right? And it would just probably just shed off. Yes, when the time comes. Yes, from given days, when the time comes, it is going to shed off. So no nuclei, no mitosis, no nothing, and the cell and the layer is dehydrated, definitely. Yes, and acts as a barrier function. Okay, so that was all about the general part about stratum corneum. Okay, so now let us continue about abnormal histopathological findings, right? So two conditions, one of it we already discussed. Yes, so in the normal finding we do not have nuclei in the stratum corneum, right? Okay, but in which condition do we have it? One of it was the psoriasis, right? And in parakeratosis there is retention of nuclei. So this is not a disease, it is a condition, it is a finding. Okay, it is a finding, parakeratosis. Okay, and hyperkeratosis is increase in the thickness. Okay, all right, and in which condition it is associated is these are the conditions. Okay, and we have a mnemonic for that as well, not as good as the previous one, but yeah, let us go on with the list, and the later part I'll be sharing you the mnemonic as well. Okay, fine. So the first one is psoriasis, eczema, actinic keratosis, seborrheic dermatitis, and squamous cell carcinoma. Okay, and the mnemonic is peas. Yes, so I don't know you guys like or not peas. Yes, so but the mnemonic is PEA and SSS. Alright, so that is our mnemonic. Okay, fine. So let us go on to the next layer, right? So what was the next layer? Yes, one question. So we are at the very top. It was corneum, then it's lucidum, right? Okay, fine. Okay, alright. So let us talk about this. Stratum lucidum. Lucidum means clear. Alright, so let me just put that up straight. Lucidum means clear. Okay, yes, and this layer is found only in the palms and soles. Okay, alright, fine. Palms and sole, it's obviously quite clear, right? So okay, fine, that is the finding of stratum lucidum. Okay, the next layer, guys, yes, granulosum, the guys, yes, granulosum, and also stratum, I'll write the other name as well, that is germinativum. Okay, so this is the one we mentioned in our mnemonic on the top, germinativum. Cool. Alright, fine. So this layer, right, a lot of things are happening over here. So let me go back to that diagram. yes, and I'll show you. Let us have a brief thing about how we will go ahead with this. Okay, fine. This is stratum granulosum. So over here, if you can see, right, this is the stratum granulosum. There are some certain pigments. Do you see? There are certain pigments. So what are these pigments doing? Yes, we have some granules, right? Pigment is not the right word. Granules, right? What are these doing? What are these imbibing? You know, a lot of details. Let us go on with it. Okay, so stratum granulosum. Okay, what are these granules, right? So first of all, keratinization is happening here. Keratinization is happening here. Keratinization means what? We have a whole topic about just the word keratinization. Yes, so you will understand more better in that. Okay, and let us just learn about the stratum granulosum. It is also called as germinativum. And the granules, we just said, there are two types of granules, right? Keratohyalin granules and the lamellar granules. Keratohyalin granules and the lamellar granules, yes. And in the keratohyalin granules, right, so there are two things, proflagrine and filagrine. Yes, so proflagrine is the inactive part. I'll write it down. This is the proflagrine. Alright, and the active part is the filagrine. So I'm pretty sure your list of vocabularies as far as dermatology is concerned is increasing, right? And we will be discussing about all these two things, yes, specifically filagrines in very greater detail. Proflagrine to filagrine. Okay, alright, so this one thing we will be learning extensively ahead as well. Okay, what does this filagrine do, and how are all the components associated with it? Okay, alright, so this is the active molecule, yes. But a clinical correlation over here is, what does this do is it aggregates, right? It aggregates all with everything, yes, just helps to bind us together, yes, aggregates in keratin and intermediate fibers, okay. And because if there is mutation in this, it would lead to two medical conditions, that is 𝗖𝗵𝗵𝗵𝗺, okay, and atopic dermatitis. We will read about this a lot extensively, yes, and we will see images on this as well, okay, but not in this chapter when these diseases come. Alright, so the next granule was laminar granules, right? Laminar granules, also called as Odland bodies. Yes, what they do is they just provide lubrication, okay, they provide lubrication to the skin, okay. And how they synthesize, because they synthesize lipids, yes, they are able to provide us a good lubrication, okay. But if it is absent, yes, so if it is absent, what is going to have is going to have 𝗖𝗵𝗵𝗵𝗺 eczema, okay. 𝗖𝗵𝗵𝗵𝗺 eczema. Alright, 𝗖𝗵𝗵𝗵𝗺, no fat, yes, steatorrhea, yes, fat in the urine, yes, okay, and is 𝗖𝗵𝗵𝗵𝗺 eczema, so no absence of the lipid component. Alright, so who makes the lipid component? The Odland bodies, okay. So just revising this topic once again, okay, how did we start with this? Is stratum granulosum, also known as called as stratum germinativum, okay, and has two granules, yes, the keratohyalin granule and the laminar granules, Odland bodies, yes. So the keratohyalin granules, they are responsible for converting the proflagrine to filagrine, okay. So this, what this guy does is just try to catch up things, you know, keep things in place, okay. And Odland bodies, they synthesize lipids, yes. And what they do, if they're absent, what is going to cause is they're going to cause 𝗖𝗵𝗵𝗵𝗺 eczema, alright. And how about the other one? It's going to cause 𝗖𝗵𝗵𝗵𝗺 vulgaris, okay, and atopic dermatitis, alright. And that is all for this layer. There's stratum germinativum or stratum granulosum, alright. So let us go on to the next one, okay. So question, which is the next layer? Yes, stratum spinosum, right? This is the next layer, okay. Pretty interesting one, also called as the prickle cell layer. Yes, so I hope you guys are very well familiar with the mnemonic. Yes, big strong guys love coffee. Yes, Okay, strong was for spinosum, big strong guys. Strong was for spinosum. Okay, all right. So the prickle cell layer, also called as prickle cell layer, is just the name. Okay, and why is called as spinosum, right? So there is this one component, it is very prevalent in this, that is the desmosomes. We will learn everything about this, okay, but not here, in the next topic, yeah, where we discuss the basement membrane and everything in a very greater details. Okay, so the spines are more prominent in this layer, yes, and they are called desmosomes. Okay, desmosomes are proteins, they just keep on attaching things, right? They are between the two cells. All right, let us see in this beautiful diagram. Yes, so these are cells, right, and the ones connecting them are known as desmosomes. Okay, and there are a lot of pathologies related to this. If there are antibodies made against this, any component of the desmosome, it just creates a whole mayhem in the body. We will read about it. Okay, alright, so just keep this one thought in your head. I will come back to this point. Okay, the next one, what does it do is intercellular bridges connecting the keratinocytes. Okay, that is what we discussed right now. Yes, and it is the thickest layer of the epidermis. Okay, stratum spinosum. Let us go back to the diagram and just see for ourselves, was the stratum spinosum the thickest layer or not? Let's go. Okay, alright, so this is the stratum spinosum, right? Big strong guys. Strong was spinosum, fairly thick enough. Yes, okay, fine. Okay, so the next one, okay, right here. So now let us discuss the cells. Okay, so let us discuss the cells. These are keratinocytes and Langerhans cells. Okay, keratinocytes and Langerhans cells were the APCs. Okay, fine. The next point is about the diseases, right? I discussed this as well. So pemphigus group of diseases is the one in which if there are antibodies made against the desmosomes, yes, even in desmosome there are part of it, yes, and which in pemphigus as well there are a lot of different types, and in each subtype there is a specific antibody. We will learn about them and I'll give you a very good way to memorize them, yes, so that we never go wrong in it. It is a very crucial point that we should memorize. Alright, fine. And antibodies against one component of the desmosome. Okay, and now comes to the very bottom one, the stratum basale. Yes, so this is the most active layer. Alright, so this is the most mitochondrial active layer. It's very obvious that the cell, the stratum basale, right, this is the one who is producing the cells, and by the time there is cell differentiation, and because of the epidermal turnover rate, right, they keep on going at the top, and they finally shed off. Okay, alright, so which cells are there? There are keratinocytes, melanocytes and Merkel cells. We will go back to our diagram as well. Okay, so keratinocytes, melanocytes and Merkel cells. Okay, so what were Merkel cells? One question to you, this was for the fine touch receptor. Okay, and the melanocytes, one component of it was responsible for giving the pigmentation. Okay, and the other one keratinocytes. Okay, the one held by desmosomes. So desmosomes are there in all parts of the dermis. Okay, alright, so let us go back to the diagram and we will summarize everything once again. Yes, okay, alright, so we just completed the stratum basale right here. I will take this opportunity and mark the whole thing out, this one, right? That is the stratum basale. Okay, so what are the cells can you see? First one is the Merkel cell, right? We see a Merkel cell and we see a melanocyte. Alright, melanocyte, Merkel cells. Which layer? Stratum basale. Okay, so let us revise the whole chapter once again. Okay, right here in this diagram. Okay, so fine. Epidermis, dermis and hypodermis. Okay, so this is the dermis thing. Okay, alright, so why do we call dermis? One reason is because we read the units, right? In that we learned about there is a very good vascular supply. Yes, and in this we can see the vascular supply. Okay, that is one point. The next one is the basal. Next term is basal. In basal we see in stratum basale, what's happening is the cells are getting manufactured and they're pushed upwards, and the two cells, there are melanocytes and there are Merkel cells. Okay, and the next layer is stratum spinosum. Okay, stratum spinosum right here. This was the thickest layer. Yes, obviously this is thickest layer, and in this we have Langerhans cells and keratinocytes. Okay, very clear about this. What does Langerhans cells do? APCs, antigen presenting cells. We will read about this very extensively. Yeah, just a point. Yes, and all these regular cells you see, these are keratinocytes. Okay, so stratum spinosum has keratinocytes and Langerhans cells. Okay, fine. As we go ahead, right, so big strong guys, granulosum or stratum germinativum. This was the layer where the keratinization was occurring. Okay, all right. So we can see we read two granules. Okay, do you guys remember we read two granules, right? So these granules were responsible for giving us a very good for giving us filagrins, yes, and lipid molecules. Okay, because of that, if there was any pathologies, yes, on one side there was 𝗖𝗵𝗵𝗵𝗺 vulgaris, and on the other side it was 𝗖𝗵𝗵𝗵𝗺 eczema. All right, because of this layer. So the reason I am repeating this is because when you listen to the name of the layer, you guys should automatically have these two differentials, at least these two differentials in the mind. Okay, fine, this and this, this and this, this and this. Okay, all right. The next one is stratum lucidum. What does this? Whenever I read lucidum, the only thing comes to my mind is it is clear. And where is it found? On the palms and feet. Okay, clear. Okay, all right, fine. The next one is stratum corneum. Okay, stratum corneum, it is at the very top. What was the shape? Flat cells. Nucleus or no nucleus? No nucleus in normal cells. So in which two type do we have nucleus? We have in parakeratosis. Okay, in which condition do we see the parakeratosis? Yes, one of it was psoriasis. Okay, all right. So that is all for this. Yes, and the next video, the continuation of this is going to be about the types of cells. Yes, in that we will be discussing about keratinization. The topic we read over here, we'll go on a very elaborative details about where is it happening. Obviously we know the location, and we'll go on to the details of each type of cells, right? The three cells we read, keratinocytes, melanocytes, Merkel cells. Okay, we'll be learning about those. So I hope this discussion was good, and this will be continued. Thank you so much for listening.